So let's start to synthesize this. So we have 7 approvals for PARP inhibitors, 3 in treatment, olaparib, rucaparib, and just niraparib in October of 2018. 19, thank you. We have 3 platinum-sensitive maintenance approvals, Nova niraparib, Study 19, Solo 2 for olaparib, Arrow 3 rucaparib. So 3 and 3. And then we have frontline Solo 1 maintenance only in BRCA. That's where we are today. And then soon we're going to have frontline maintenance beyond BRCA. So we'll probably have 3, 3, 1, 7. We'll have 10 FDA approvals of PARP inhibitors. And then ultimately we'll get to combinations, which we're not going to talk about today. We also have 3 bevacizumab approvals. Frontline, we just talked about it. Platinum-resistant, this Aurelia trial with single-agent chemotherapy. And then Oceans and GOG 213 with platinum doublets. That's what people look at as chaos. Let's bring order.
Okay.
So here's how we do it.
All right.
So when you see a newly diagnosed advanced ovarian cancer, you have 2 decision points.
Right.
In the beginning, and then at the end of 6 cycles. So I think you have to look at these 2 decision points, and they're connected, because what you did with the first decision point informs the second decision point. Absolutely. Can we agree, I'm not sure we can, let's try, that at the first decision point, when you start a patient on chemotherapy, you're probably not going to have the HRD back? Correct. Right, yeah. So there are some people, well, I'm going to get it back, I get it, takes a week. Listen, the pathologists are not going to release the tissue that quickly. Then it takes time to process the specimen, and you are motivated to get your patient on effective treatment. Okay. So at the first decision point, let's go through the choices. Chemotherapy alone. Chemotherapy Bev. And if veliparib gets approved, chemotherapy veliparib. How do you make that decision? First decision point, chemotherapy, chemotherapy PARP, chemotherapy Bev. How do you make that decision?
Yeah, I mean, for me, chemotherapy alone is becoming less attractive.
Yes.
And I think that pushes you towards the other 2. There's still patients that are frail, might have a lot of bowel involvement,
Stage
what
2
have you,
patients, or at least
high-grade hypertension, other patients that are not as high risk. But as you know, if the disease is outside the ovary, these patients are all at pretty significant risk.
Right, and they need maintenance.
They do.
Either with Bev or with PARP.
That's right.
Okay, and I say, you guys have been making the decision to use Bev or not since June of 2018. You're comfortable making that decision? Yeah. So if you decide to use bevacizumab, you're probably not going to stop it, okay?
Well, that's where, and you've taught us this, Brad, that coupling between decision point 1, decision point 2 is much firmer than what people want to admit. Right. It's very true, and take us through that, because I think it really illustrates how if you start going down one road, you're probably going to, the momentum will keep you going on that road.
The momentum will keep you going. Yeah. So if you start veliparib, you're kind of at the second decision point, assuming she doesn't progress, continue it. If you start bevacizumab, you're going to continue it in the maintenance phase, and if she's BRCA or HRD, you're going to layer olaparib. That's pretty simple. Yeah. And if you are chemotherapy alone, then at the second decision point, you can either add olaparib alone if she's BRCA, or niraparib if she's not.
Correct.
Or even if she is.
Correct.
What do you think about that?
No, I think that's, so you'll see varying uses then, right? So I'm probably going to use more than niraparib based on Prima than you will because of that, because I don't use as much Bev. Right. But still trying to figure out about that combination, which group, we'll get some more subgroup analysis, and it'll be fun to flush all this out. I think there'll be more clarity as we move forward, but we'll never be able to get around the fact that these have different eligibility criteria, and it'll be hard to really tease out. But I do think there's some questions about all these trials that we will hopefully answer with some additional publications and get a better understanding. The other thing is going to be the label. The label guides a lot of things. So what will that label look like for niraparib, for example?
It's got to be all comers, because all the subsets are positive. One of the things I'm excited about, though, in the HRD negative group is that although the PFS is short, because the prognosis is so poor, the survival data is maturing very quickly. So we'll probably have the overall survival for the HRD negative patients by the time it's approved And if there is a survival benefit, maybe that will be interesting and persuade people.
Again, that group had an impressive hazard ratio, 0.68.